Hello, everybody. I come to you today to talk to you about my population of vulnerability. My name is Lakita Underwood, and this is Social Work Intervention. The population of interest that I chose is substance abusing pregnant women. Why, you ask, is this population vulnerable? Opiate use disorder in the United States is rising at an all-time high, and particularly among women of childbearing age. Prescription opiate misuse and illicit heroin use has skyrocketed, with overdose deaths quadrupling. With opiate use disorder comes the high incidence of unintended pregnancy. How are they vulnerable? These women face a host of complex issues. They come from all social and economic backgrounds, complicated by psychosocial and environmental factors. Often there's a history of sexual abuse or interpersonal violence, inadequate social supports, and co-occurring psychiatric conditions. Unpredictable parenting models. Some women are not prepared to become mothers or don't know how to be a mother. Unstable housing. They may be homeless now, or once they have the baby, become homeless. Poor nutrition. They probably were not eating healthy prior to becoming pregnant, and most definitely are not eating healthy now. And they're likely using multiple substances during pregnancy that include tobacco and alcohol. If the substance abusing pregnant woman does not seek help, she could run the risk of neonatal abstinence syndrome. And this is caused primarily by maternal opiate use. The severity of these symptoms experienced by the infant depends on different factors such as the opiate the infant was exposed to and whether or not they were exposed to multiple substances. Barriers faced by this population. There are numerous barriers faced, such as limited access to treatment, the types of treatment available, the cost, is it affordable, the stigma. Once the woman becomes pregnant, she's afraid to tell anybody because she know that she's using, and then it runs the fear of legal consequences such as, well, I don't want DHR to take my baby, or I don't want to go to jail, and all of these things take into play, and it affects the woman actually seeking treatment. The best evidence-based practice with this population is cognitive behavioral therapy, CBT. Psychotherapeutic treatment to help patients understand feelings and thoughts that influence behaviors. CBT is used to treat addictions, phobias, depression, and anxiety. This type of treatment is generally short term and client focused on helping deal with a very specific problem. Individuals learn to identify and change disruptive or disturbing thought patterns that have a negative influence on behavior and emotions. Pregnancy can be a powerful motivator for the woman to stop using, but sometimes it's not enough. Skills are taught to improve health outcomes such as relapse prevention, parenting skills, practicing safe sex, use prescribed active healthy coping behaviors, and also the person-centered counseling approach, identifying the person's readiness to change. Relaxation training, homework assignments, close attention with connection of unhelpful thoughts, emotions, and substance use, targeting drug use behaviors, improving health outcomes. Go beyond addressing substance use to addressing the co occurring problems and providing skills for managing future emotional distress. Preferred treatment for the population. Available treatment options for this population are opiate agonist treatment, and this can include detox, methadone maintenance, or Suboxone, and it really just depends on where the woman is in her pregnancy, and also a physician needs to determine what type of treatment would be best in the best interest of the woman. But this does remain the standard of care for treating opiate use disorder. Medically assisted opiate withdrawal detoxification is not recommended in pregnancy and is associated with a high maternal uh, relapse rate. And also, like I say, they do detox at the beginning of the pregnancy, but later on in pregnancy, it is discouraged. Goals of treatment: manage withdrawal, reduce cravings, prevent illicit use, which can increase the risk of fetal growth restriction, and have a healthy and happy pregnancy. Community resources. Many communities have developed collaborative initiatives to make systems and processes work more effectively. Effective screening and linkages to treatment in the prenatal period are easier. The OBGYN will work with the woman to help her find the treatment that she needs. Effective communication between the hospital and community partners. Also, available residential programs. I live in Florence, Alabama, and we have two residential programs in my area, a New Beginning and Freedom House. The health department offers services such as WIC, Women's, Infants, and Children's. The Department of Human Resources has food stamps and TANF. Available treatment, as we discussed earlier, were detox, methadone maintenance, and Suboxone. And there are prenatal care programs that the hospitals offer on a monthly basis. I know my hospital offers my two hospitals offers the programs as well as Huntsville Hospital. The advocacy plan, all pregnant women should have access to affordable prevention and treatment services. Women should not be excluded from accessing health care because of their substance use. Residential programs should incorporate consideration for the infant and siblings. Dignified, multidisciplinary treatment options for pregnant women. Initiative of pharmaceutical treatment for mental health disorders must consider maternal efficiency. Intervention should be provided in a way to prevent stigmatization. Discrimination, criminalization, and marginalization of women seeking treatment should be discouraged. Pregnant women with opiate use disorder should be co-managed by an obstetrician and an addiction specialist physician. This population can be empowered on all levels, from the general population to community members, policymakers, and especially social workers. As we all know, we are in an opiate epidemic, and it will not end if we do not work together. Here is a list of references that I used in my presentation. And I hope everybody has a good rest of the semester. And I thank you for taking the time to listen to my presentation. Thank you.